Okay, let's go ahead and get started. Welcome to Medical Grand Rounds. Thanks for joining us. I'm David Schwartz, Chair of Medicine. This presentation is going to be recorded for future reference. You'll be muted upon entering the meeting. At the bottom of your screen, you'll see a Q&A icon. Use that icon rather than the chat feature to submit your questions. I'll be moderating the question answer period at the end of the presentation. Race, income, and zip codes have become familiar risk factors for who becomes infected and dies from SARS-CoV-2 infection. Neighborhoods with high concentration of Blacks and Latinos, as well as low-income residents, suffer the highest rates of death, while wealthier communities experience sometimes no deaths at all. As healers and investigators, we need to understand these critical determinants of health. More specifically, we need to understand the drivers and the solutions to the health disparities associated with COVID-19. Today, we have 4 outstanding speakers with expertise in this area. The lineup includes Dr. Shanta Zimmer, who will present the local and national prevalence of COVID-19 infection, demonstrating the role of race in the distribution of this disease. Dr. Lilia Cervantes will discuss the social determinants of health. Dr. Carlos Franco-Paredes will discuss the distribution of COVID-19 in jails and prisons. And Dr. Katherine Dickinson will present the role of policy to address the racial disparities seen in COVID-19. Okay, let's go ahead and get started. Dr. Zimmer is up first.
Great. Thank you, Dr. Schwartz and Dr. Flores for inviting us to talk about this important topic. Advance my slide here. My job is really to set the stage, and I would like to do that by really describing what the pandemic looks like. First, I want to remind everyone that race is a social construct, not a biological one. I'm going to describe the distribution of COVID infections by race and ethnicity nationally and also closer to home, and then list hypotheses for why these disparities exist, which my colleagues will then expand on when I pass the baton to them. First, to make sure that we're all on the same page in terms of baseline data, I have 2 graphic pie charts here demonstrating the US population broken up by race and ethnicity. To be consistent, I tried to change all the graphs in the presentation to make sure that the white race was represented by the color blue, which you can see nationally is around 63% of the US population and 67% of the race of Coloradans. Consistently throughout the presentation, Hispanic race, which is actually an ethnicity, will be annotated by the orange color, and Black or African American in green. On March 27th, 2020, during the midst of our pandemic, Illinois was the only state that was reporting data nationally by race and ethnicity. They released information about the disparities that exist in the state, and immediately representatives from Congress and the Senate called for more transparency. Elizabeth Warren and Representative Ayanna Pressley are quoted here in a letter that they wrote to the State Department and the Health Department. Any attempt to contain COVID-19 in the United States will have to address its potential spread in low-income communities of color, first and foremost to protect the lives of people in those communities, but also to slow the spread of the virus in the country as a whole. Although COVID-19 does not discriminate along racial or ethnic lines, existing racial disparities and inequities in health outcomes and healthcare access may mean that the nation's response to preventing and mitigating its harms will not be felt equally in every community. After that call for transparency, the CDC was under some pressure, and what I show here is a graphic representation of the states that are currently reporting confirmed cases by race and ethnicity. And you'll see that almost the entire nation is reporting by race and ethnicity in response to this call for transparency. The CDC, just a few days after that initial request, published the rates of hospitalizations among 14 states. that only constituted about 1,500 coronavirus patients. And even with that early data, despite making up only 18% of those who were reported and studied, Black Americans accounted for a third of all severe cases. So here's a breakdown again of the cases that were reported from those initial 14 states. You've seen a lot of attention placed on this issue in the news media, and my colleagues are going to present many different hotspots. I just highlight this one here from New Orleans, where the Black community has been disproportionately impacted by rates of 2 and 3 times compared to their white fellow citizens. These data represent a national call to attention of the disproportionate effect on Black Americans. What you see in the graphic on the left-hand side is early in the pandemic, once the disparities began to be reported, you see in the green dot the percentage of population in the particular area. So in the District of Columbia, for example, roughly 45% of the population is African American, yet the percentage of deaths in the blue dot here, 75% of the deaths in that area have been among African Americans. The distance between the actual population of the area and the percentage of deaths represented by that population are here in the brown bars between the green and blue dots. Here in Colorado, CDPHE is representing on their website the number of cases, percentage of deaths, and again, a reminder of the breakdown of the racial and ethnic minorities in the population. And what you see here is that the percentage of cases in African Americans is around 6%, but the population of Colorado is only 4% African American. Similarly, in Colorado, we see that the Hispanic community is represented by about 21% of the state, but they are 36% of the cases. So these data are available now on our website, and the transparency from the State Health Department has been excellent in Colorado. A little bit closer to home, in the hospitals that participate in our university setting, we look at, with help of our medical students, the race and ethnicity of the patients who've been hospitalized at Denver Health here on the left-hand side, and at the University of Colorado Hospital on the right. And again, keeping consistent with my earlier color scheme, blue represents white patients in our hospital, and yellow represents Hispanic. Green are the African American patients. And thanks to the medical students and to Dr. Sarah Rowan at Denver Health, Dr. Christine Erlinson at University of Colorado Hospital for doing the intensive chart review that's required to make sure that we capture these data. So closer to home, approximately 80% of our hospitalized patients are non-white. Looking to our colleagues in the Veterans Hospital, nationally, if you look at the race and ethnicity of our veteran population, 78% of veterans are white, 17% are Black, and 7% identify as being Hispanic. They have been, however, differentially impacted by COVID-19 as well. And these are data from the newly minted Dr. Sarah Hager, Dr. Michael Ho, and Abby Bryant, who were working on this project at the VA, where 45 to 57% of patients who tested positive or were hospitalized were non-white. And again, you see overrepresentation of African Americans in this group, 36%, and 27% of all COVID positive patients. Thanks to Sarah and Michael and Abby and the other students listed here who participated in the COVID follow-up study, they calculated odds ratios for both testing positive, being hospitalized, and also being in the ICU based on your race. So in this second to last column on the right-hand side, if you compare being African-American veteran to being a white veteran, the odds of testing positive was 2.12. And the odds of hospitalization in the ICU is actually 3.97, almost 4 times more likely to be hospitalized. Similarly, our Hispanic veterans were 6.7 times more likely to end up in the ICU than the white veterans who were COVID positive. We see differences elsewhere besides COVID, obviously, in our society. And the pandemic has brought up differences in social isolation, the ability to do so, housing insecurity, incarceration, the security of your immigration status, the ability to take paid sick leave or to take time off from work, financial stability or instability, language barriers, lack of childcare during the school closings that we've been experiencing, and higher rates of diabetes, hypertension, asthma, and obesity, the comorbidities that are known to be associated with more severe disease. Grounded in these comorbidities, however, are other inequities of access, bias, poverty, lack of education, and environmental factors that are identified through some of the zip code studies. There has been a call for research, and I was actually happy to see this call coming from across the pond. So this is a study for a call for extended research in areas that contribute to these disparities, looking at not just the tip of the iceberg, which would be the things like genomically determined response to viral pathogens or to sepsis, but really looking at bigger contributors, intergenerational interactions, people living in multiple levels in one family, health behaviors such as consulting patterns and health access, understanding COVID-19 and the messaging that may come out about social isolation, and then the health state of the individuals, including the comorbidity treatments and the burden of those comorbidities. If you're interested in looking at broader sets of data on the race disparities in COVID-19, this website, covidtracking.com, is updated on a daily basis. So in summary, for this introductory portion, nationally and in Colorado, significant racial disparities in cases and hospitalizations exist. Our local data from our School of Medicine partners demonstrate that 50 to 80% of our hospitalized patients are non-white, and factors contributing to these differences must be investigated. The next speakers are going to discuss solutions, which will include disruption of the structural racism that contributes to these disparities. And before I pass it over to Dr. Cervantes, I just want to end with this quote in an interview from Dr. Blackstock about what's at stake here. Our humanity is what's at stake. If we don't think about the most vulnerable members of our society, what kind of society are we? We talk about all the values of living in this country, but if we don't care for each other, we don't take care of the people that really have the least, then we are on a really very dangerous course. Thanks, Lily.
Thank you, Dr. Zimmer, and thank you, Dr. Schwartz and Flores, for bringing us together to discuss this important topic. I'd like to offer some possible explanations for the increased case and death rate we're seeing in minority groups. I'll begin by anchoring our conversation on the biological and social determinants of health, and then I'll briefly provide some evidence linking where and how we live to COVID-19. And then end with a brief description of some of the challenges faced by undocumented immigrants. Some believe that the higher rate of infection and death that we're seeing in minorities is due to biology, and it is a factor, but not a dominant factor. And so humans are genetically very similar. While our external characteristics or appearances such as skin tone and hair color show a lot of variation, we are still mostly the same. The Human Genome Project and the more recent 1000 Genomes Project show that because humans have a shared ancestry, very few gene variants exist among populations globally. And as Shanta said, race is truly a social construct. Many argue that there are not enough genetic and biological differences among humans to uphold the idea of distinct races. And so in place of that, I'd like to describe the prominent way in which groups differ from one another, which are predominantly due to social, environmental, and behavioral life patterns. Again, it's not that genetic differences have no impact. Genome studies with diverse patients should continue and have important health considerations for genetically based disease, but these differences comprise a smaller contribution to health and premature death. As you can see in this figure, determinants of health and their contributions to premature death are primarily social factors. These are aggravated in populations with resource deprivation caused by low socioeconomic status, place-based risk based on neighborhood, chronic stress brought on by racial discrimination, as well as behaviors such as smoking and substance use. The key, again, is that we need to refocus our attention on these social factors and the class-based factors and not on race. This figure illustrates the social determinants of health using the framework provided by Healthy People 2020. If we focus in on COVID-19, we can consider how each domain links to the disparate impacts that we are seeing. So starting at the top with economic stability, there are many people that cannot shelter in place because they cannot work from home. They're providing an essential service. They're using public transportation to get to work. Many face unstable housing and live in close, condensed neighborhoods, sharing bedrooms or bathrooms. And because of poverty, many people cannot order their food online or even have access to cleaning supplies. Looking at education, education influences health behavior. And for many, English is not the primary language, and there's insufficient information on COVID-19 that is language or culture concordant. With regard to neighborhood and built environment, there are fewer parks in poor neighborhoods, and so as we begin to reopen, you can imagine those parks being more densely crowded. And if you think about social and community context, there are many immigrants and refugees that have expressed that they do not feel safe, that it's safe for them to leave their home or access medical services due to perceived racism and discrimination. And finally, with regard to health and healthcare access, we still have many uninsured in the country, especially in those states where there was no Medicaid expansion. And then also undocumented immigrants, for the most part throughout the country, do not have access to care, especially COVID-19 care. And so you'll be hearing about structural racism from my colleagues. You may have heard the word structural inequality as well. This refers to the unequal distribution of power and resources based on race. And it's rooted in the belief that minorities need only the bare necessities, which reduces access to healthy food, safe working conditions, medical treatments, and other social inequities. And I realize that these words, especially the word racism, they make people uncomfortable. But I think rather than avoid it, I think we need to really focus on it and talk about it. This map shows the distribution of hotspots throughout the country, and each hotspot has its own story. In New York City, there are 5 boroughs. The map on your right shows the distribution of race and ethnicity, and as you can see, Manhattan is primarily green, which is non-Latino white. The Bronx is one of the most ethnically diverse areas in the US. More than 500,000 immigrants live there, many speaking a language other than English. And it's ranked the least healthy of New York State's 62 counties, due in part to decades of policies related to housing, education, and criminal justice. A research letter published in JAMA described the distribution of COVID-19 cases and deaths across the 5 boroughs in New York City. Important findings were that compared to the other boroughs, Manhattan is more densely populated. It has the highest proportion of older adults and non-Latino whites and the highest median income. The Bronx had the highest proportion of Blacks, the lowest median income, and the lowest proportion of persons living with a bachelor's degree. And so it's perhaps not surprising that among the boroughs, the number of patients with COVID-19 who were hospitalized and the number of deaths from COVID-19 per 100,000 was highest in the Bronx and Queens and lowest in Manhattan. And so even though Manhattan has the highest population density and older adults, they had the lowest number of hospitalizations and deaths, indicating that other factors such as social challenges and race-based structural inequities explain the disparate outcomes. In San Francisco, 3,000 residents and workers in the Poor Mission District were tested. This is a very poor community that is predominantly Hispanic, and its workers provide an assortment of essential services. Of the 3,000 people tested, about half of them were Hispanic. Yet of those that were positive, 95% were Hispanic. And looking at the bottom, you can see that those that were positive, the majority reported not being able to work from home, earning below $50,000 per year, and living in a household of 3 to 5 people. This slide illustrates the various neighborhoods within Denver County, and so you can see the trend here. in this map, the darker purple indicates a higher proportion of individuals living in poverty. And what I wanted to just show you is that the neighborhoods that are outlined in red are those neighborhoods where we have seen higher cases and deaths. And this is based on Colorado state data. And one of those neighborhoods, or actually two of those neighborhoods, are the two neighborhoods that I grew up in, Valverde and Westwood. And they tend to, you know, have a very high number of immigrants or undocumented immigrants, people born from foreign countries. And those are the same neighborhoods that have a lower life expectancy compared to wealthier neighborhoods that live nearby. And so low socioeconomic status is a risk factor alone for total mortality, independent of other factors. There are examples of outbreaks and hotspots related to densely populated communities with poor resources. The Navajo currently have the highest COVID-19 infection rate in the country. In this community, over 40% of people there live below poverty, and many don't even have running water. There are generations of families living under one roof. And then I wanted to end by describing the challenges faced by undocumented immigrants. As many of you know, I work very closely with this community. Many face language barriers, and as I mentioned, there's insufficient information that is culture and language concordant. Many fear accessing medical services because of ICE. The administration had announced that ICE would seize civil immigration enforcement actions during the pandemic. However, reports have surfaced that enforcement has continued in some areas. People also fear accessing medical services because of the public charge rule change, which went into effect during the middle of February, around just days before the first reported instances of community spread of COVID-19. This rule makes it harder for immigrants to adjust their immigration status if they use forms of public assistance like Medicaid. As many of you know, undocumented immigrants do not have access to Medicare. They also don't have access to the provisions of the Affordable Care Act, and they're also excluded from many federal Medicaid programs. Interestingly, though, the emergency Medicaid program allows each state to sort of define what constitutes a medical emergency. And as many of you know, in February of this past year, they decided to include kidney failure. And so undocumented and uninsured patients that at that point had access to dialysis. And so I'm excited to announce that this past Friday, Colorado joined a handful of states that expanded access to COVID-19 care for undocumented and uninsured patients by similarly modifying the emergency Medicaid definition. And so that's a huge win and very exciting. And so in summary, a focus on race based upon any biological or genetic difference translates into blame of minority groups for COVID-19 rates. Poor neighborhoods came into the crisis with already high rates of chronic disease, chronic stress, and poor access, thereby increasing their risk of more severe COVID-19 infection. And because of social challenges, they have an increased risk of exposure. And I'll pass the baton on now to Carlos.
Thank you, Shanta, and thank you, Lily, and Dr. Schwartz and Dr. Flores. So what I will focus the next few minutes will be the impact of COVID-19 in terms of jails, prisons, and immigration detention centers in the US. And one of the things that I would like to start with is by reminding you that in the history of mankind, the history of infections impacting mankind have influenced the establishment of societies. And one of the important things has to do with human behavior, patterns of human behavior such as migration, but some of them have to do with living in congregate living environments such as villages, cities, and so on. And the reason being for that is infectious diseases have acted as, in a way, agents of natural selection, and in general as the wildcards of history. to move there, from there, one of the books I read a few years ago that impacted me was The Plague by Albert Camus, and probably it's becoming now very famous, or more famous than it used to be. But the thing is that the story is concentrated in an Algerian town in the coast of Algeria, the town of Oran, and the main character, Dr. Rue, is a physician who basically, and the public health response agent, who stays, in some of the dialogues in the book, talks about decency, which means just basically doing our jobs in caring for others and decreasing suffering during this plague pandemic. And I think I would use this example to finalize this presentation, but I think the main driver for what we do, as Shanta stated, is humanity, but is also acting with decency and doing our jobs in caring for those that need it the most. So due to, I would like to say, Michelle Haas, Yanin Young, Jamie Moo Young, Hilary Donlevy, Megan Robbins, and many others who got involved some time ago in providing assistance or working with lawyers, civil rights attorneys at the Immigration Detention Center here in Aurora. Subsequently, my role in writing some of these declarations that I point here went to the correctional facilities, jails and prisons in the state as well as in other states. And I had the opportunity to do in-person inspections of many of these jails. And I have seen, I would say firsthand, the impact of the COVID-19 pandemic, and that's what I would like to present to you in the next few slides. So just a brief epidemiologic summary of what I'm referring to. So if we think about these three different waves that are not exactly distinct waves of COVID-19, I think, we can trace back, they're overlapping waves, so we cannot really say wave 1, 2, or 3. But the first wave we can pinpoint towards the end of January, where some at-risk populations in nursing homes, assisted living facilities, as well as some unsustained transmission in the Pacific coast of the US territory were identified. Subsequently, from there, what we can call the second wave, from early March to the present time, with sustained transmission in the larger communities in the inner city, and so on, as it happened, in Denver or in New York, in other places. But what is interesting is that the last third wave, which reached the basically correctional facilities starting in the state of Georgia, as well as in other large facilities like Cook County in Chicago and Marion, Ohio, and many others, is that correctional facilities have become the hotbeds or the epicenters of transmission at this point in the pandemic in the US of cases of COVID-19. So one of the things that I like to talk about is one Mr. M, who I met, and his cellmate or cellie died from COVID-19, and this is here in Colorado. So he asked me, is getting COVID-19 and dying from it part of the package of being incarcerated? And that's when it became clear to me that there were two very different things, because public health in prison is public health in the community as well. So COVID-19, if we look at the overall impact of COVID-19 in correctional facilities, and that means jails, prisons, and juvenile detention centers, the best data reported or collected is actually by the UCLA Law COVID-19 Behind Bars project, which I have been collaborating closely with them. And then this data is basically from websites reported by states, counties, as well as the facilities. So what we see here is a growing number of cases of people who are tested, and we know that in jails and prisons there's significant under testing and under reporting. So this number, we're following it on a daily basis, we can say that this number, is basically very small compared to what probably the reality of the cases that are happening. The second point I would like to tell you is about deaths. So there's about 446 deaths, and you may say, well, it doesn't match the 100,000 deaths that have been reported overall. But the thing is that these deaths are preventable because there's different interventions that we could use to prevent these deaths. And the last part that I want to show you is that there's been also a significant number of cases among people that work in these correctional facilities. And the interesting part of the story here is that also, not interesting but sad, is that there also been deaths, as you can see in this fourth column or fifth column among correctional staff. And the other last point here is that many of these transmissions have initiated, particularly one inspection that I did and reported directly to a federal judge, was a case in Prince George's County, Maryland, where it was very clear that the outbreak began in the officers' lounge, dinner lounge, where the first case was the lady who transported the meal trays for the officers. And then she passed infection to the 4 people who worked in the kitchen. And then those 4 people then went back to their units and caused a very large outbreak in the jail. So the mass incarceration in the US, the criminal justice system, there's about 2.1 million human beings confined in prison and jails in the US at any given time. Probably right now that may be slightly lower because there's been some depopulation of the jails. But about these 500,000 stay in jails, and they're not criminals because they haven't been sentenced. In at least 90% of them are there, and maybe for a long time because they don't have the money to pay for their bail. The failure of this mass incarceration policy, is basically because it has failed to address the actual causes of drug use, for example. It's quite expensive, and it has also deepened racial inequalities as seen here. But what the COVID-19 pandemic has unveiled is also that there's a public health risk. The other part of the story is these immigrant detention centers, as the one that we have here in Aurora, where there's been also significant under-testing. And we know now that when we see 1 or 2 cases in a facility of holding more than 500 individuals, usually then is just the tip of an iceberg where we have these large outbreaks in these facilities. And connecting to what Lily and Shanta said, these structures, shackles, or structures are shackles, like in the movie Batman, is basically everything is connected, and we can trace back the fact that, you could be in jail and have the same structural vulnerabilities as if you live outside in a community, and that explains this revolving door of encapsulation of so many people, particularly African American and Hispanics. So the other factors, as we talk overcrowding, so the US has 25% of the correctional facilities in the world, and that explains, one of the important factors here is how we're seeing so many outbreaks compared to other places. Plus, for example, Iran, the country of Iran, at the peak of the outbreak, they decided to release between 70,000 to 100,000 inmates, which actually decreased the impact on jails as well as in the community. Here, the decarceration movement has been successful in some states like California by decreasing some of the numbers, but those numbers are not enough. The other factor that's important is in jails, you find people with multiple chronic medical conditions, and one of the important or interesting aspects is that aging is accelerated during prison. And if you are 65 in a community, that automatically makes you, like, if you're 55, you qualify as somebody having 65 years of age outside the prison. So there is this all confluent factors to cause these exponential high attack rates in some of these facilities. Plus, as I mentioned, the officers tend to be the ones, in a way, transmitting the new cases or the new inmates in these revolving doors in jails and with less degree in prisons. Finally, in terms of transmission dynamics, I think one of the important aspects of the R0 is the frequency of contacts in the population. And this is where I think jails or these very confined spaces facilitate the transmission of these highly infectious organisms by pre-symptomatic and asymptomatic individuals, not only those symptomatically. The other thing that we've I would say have witnessed in different ways is that insufficiency of CDC guidance in providing sufficient tools to help interrupting transmission. And there's this letter that we'll have coming out tomorrow in the New England Journal of Medicine, where my colleague Martin Kershak and Andres and now we put together some of these evidence where we found that there is a need for broader testing in these correctional facilities, because that's the best way to guide your population management, including isolation or quarantine. And same with the temperature checks. Temperature checks are useless, and I'm sorry to use that word, but they're useless in a correctional facility because they actually provide this excess over reliance on this measurement. And you may have all the symptoms of COVID-19, but if your fever, or excuse me, your temperature is not 101, or you're not basically dying, they usually don't pay attention to people's complaints. So in summary, the best practices that we learned is that number one issue, taking it to the bigger policy perspective, is depopulating jails, prisons, and ICE detention centers is the only means to achieve meaningful social distancing. And secondly, is that protecting the medically vulnerable, whatever we need to do, and we're working with different jails in this aspect, is to, if you get to a point where you feel that there's no way politically to release more people, social distancing interventions, try some of these in the best possible way, continue to infection prevention, wearing a mask, dispensing soap, cleaning supplies. But the key point here is, you're flying blind if you don't do testing. And testing here, for example, at Sterling has shown that when there were only 8 symptomatic cases, confirmed cases, it showed that basically there were more than 250 people infected. So the decency plan that I was speaking about earlier is that, what I think this pandemic has shown in the community, as my colleagues have presented, as well as what I'm presenting you inside these correctional facilities, is that unveil these underlying deep gaps or these huge health inequities. And it's not a coincidence that we're seeing the impact among these very underserved communities. The second thing is to protect the medically vulnerable, and that's what we try to do. Moving around political issues, we always try to find, in a very positive and diplomatic way, talk to the jails and prisons about ways to protect the medically vulnerable. And the last part that I think, I learned the most from Shanta, we have a class at the School of Medicine that she started recently, and I'm one of the 2 people who coordinate the class, is that we need to, incorporate these teachings into the medical school curriculum, because one part of what we do is the biological part, and I think we do a pretty good job. But the biographical part of people's lives and why they end up in jail and so on is crucial to understand also why this pandemic has affected so many people. So in terms of policy change, we talk about this compassionate release. And then after the pandemic recedes, I think it's crucial to maintain reductions in the census and decarceration. There's good examples in New York, New Jersey, that by, providing parole or probation instead of incarcerating so many people, it actually reduces crime, it reduces cost, and then you can use that money to provide programs for the community, for community development, and reducing crime overall. The other thing I would like to say, UC Health has this policy of not, having the ability to see outpatient clinic in the outpatient clinics incarcerated patients. I think we need to, personally, and I think many people agree, rethink this policy, because now that we're in the need also to re-establish our clinics after this pandemic, is that there's a big need out there in these jails, and not being able to schedule patients in the outpatient clinics except for the ID clinic has been a major barrier to provide adequate medical care. There's reimbursement and Medicaid rates, but it's better than nothing. And I think we will feel that in this letter we signed many, that is a stigmatizing policy. So the last part is I want to leave you with this quote, and then again, thank everyone for support. There's a lot of people behind me. Jamie Solis, one of the medical students, Michelle Haas, Hillary Donlevy, Megan Robbins in the clinic, as well as Shanta and many other people, including Eric Peschel as well, my division director, who have supported me to be able to achieve these projects. So thank you. And I will pass the baton now to Katie.
Thanks, everyone. I'm really happy to be a part of this panel. My name is Katie Dickinson. I'm an assistant professor in the School of Public Health, and my PhD is in environmental economics. My research examines the impacts of environmental policies on health behavior, health outcomes, and social well-being, with a focus on environmental and social justice issues. So I have have three takeaways for my portion of the talk today. First, structural racism, which I am going to define in terms of policies that uphold racist systems, are responsible for racial disparities in COVID-19, as well as many other health outcomes. Second, racial disparities are linked to policies that influence exposure to COVID-19, susceptibility, and access to care. So who gets sick, and then what happens to people once they are sick? And I will talk mostly in my talk about the exposure pathway today. And finally, eliminating health disparities in COVID-19 and beyond requires anti-racist policies. So I'm going to start by giving a definition of racism. So many of us have kind of grown to think about, racist, sorry, I'm a slide ahead of myself. There we go. Many of us have been taught that being racist is an active, abhorrent, and currently somewhat rare character flaw. However, Ibram X. Kendi and other scholars challenge that definition and argue that racism is a much more pervasive system of laws and policies that have been with our country since its founding. So Dr. Kendi argues that racism is kind of like the air we breathe, largely unintentionally. Every one of us is racist much of the time, and rather than striving to not be racist, our goal should be to actively combat our racist thoughts and actions by being anti-racist. This means identifying and working towards policies that undo structural racism. As one example of the way that racism is baked into our social systems, this article illustrates how an old policy, redlining, continues to reverberate today, long after the policy itself was ended. So as this nice article that came out yesterday in the conversation shows, in the 1930s, the federal government designated areas of major cities as more or less risky for banks offering home loans. These red line maps were explicitly tied to racial demographics of different neighborhoods. The effect of this policy was that people in risky areas weren't able to get loans and were thus not able to accumulate wealth through homeownership. The Fair Housing Act in 1968 banned racial discrimination in housing, but the effects of this policy persist. Notably, again, as this nice article shows, COVID-19 hospitalization rates are higher in formerly redlined areas of Denver, including the areas that Dr. Cervantes mentioned earlier in her talk. And in fact, beyond sort of this overlay, a wide range of amenities follow the same pattern, these same patterns. So for example, this map shows surface temperatures, which are tied to green space, trees, other elements of the built environment that also follow this very strong social patterning or spatial patterning that is linked to this legacy of redlining. So given this uneven policy landscape, while it may be true that we're all in the same storm when it comes to COVID-19, we are in very different boats. Or to borrow another phrase, when white folks catch a cold, black folks get pneumonia. Interestingly, this saying actually originated as a metaphor in the context of the effects of economic shocks, but it's quite on the nose when it comes to the current situation. So moving on to my second point, policies shape exposure to COVID-19 as well as susceptibility to illness and quality and access to quality care. I think the other two speakers have talked a little bit about susceptibility and access to care as well as exposure. I'm going to focus mainly on exposure. So Dr. Franco-Paredes mentioned this in his talk. The contact rate plays an important role in how COVID-19 spreads within a community. So is a key factor in determining this R0 value for the pandemic. The goal of physical distancing and stay-at-home orders has been to reduce that contact rate, right? To reduce the number of people that any one of us comes in contact with. However, the ability to keep distance or to stay at home is clearly linked very closely to one's occupation and livelihood. Some job functions require people to work in close proximity to others. Many of you are well aware of the healthcare workers as one very key example, right? But many other examples as well, including things like people working in meat packing plants, which, as mentioned, has been one of the major hotspots in Colorado as well as. So if occupation plays a key role in exposure, we also know that occupation varies significantly by race due to many structural factors and policies related to, for example, funding of education through property taxes. So to take a closer look at some of these factors influencing exposure to COVID-19 and to look at how risk perceptions and behaviors change over time as the pandemic unfolds, Colleagues and I have undertaken a study with funding from the National Science Foundation that involves surveying residents of 6 states at 3 time points. The first wave of this survey is just wrapping up. As of 10 a.m. this morning, we had collected 2,259 responses. I'm going to show some results in the following slides for the Colorado sample in particular. 391 respondents so far, whose demographics roughly match the demographics of the state. Note that these results are preliminary as data is still coming in. So similarly to what Dr. Cervantes showed earlier, our data are showing us that there are important racial disparities in who is working outside the home and who is able to keep distance from others most of the time, with white respondents more able to avoid COVID-19 infection through these behaviors than non-white respondents, particularly Black and Hispanic respondents. Interestingly, we do not see the same pattern when it comes to wearing masks or face coverings, so there's a more even distribution for that protective behavior. We also ask people about specific barriers that would prevent them from taking certain preventive actions. We find that a higher proportion of Black and Latinx respondents reported needing to leave home to take care of family members. In the Colorado sample, we actually don't see significant differences in reports that people are not able to keep distance from others while at work, but we do see that in the national sample or our 6-state sample. And finally, consistent with what has been reported elsewhere, we do find that non-white respondents are more likely to report that they fear being seen as a criminal or being stopped by the police when wearing a mask. And lest you think that these fears are overblown or unfounded, there's ample evidence that Black people are seen as dangerous in this country in a wide range of circumstances, doing very normal things in daily life, and too often this has fatal consequences. So finally, while this talk has been focused on disproportionate health impacts of COVID-19 on communities of color, the economic impacts of the pandemic are also very unevenly distributed. Our data show that non-white respondents are more likely to report being laid off or furloughed due to COVID-19 and are also significantly more concerned about running out of money in the next 3 months. Given these disparities, it is clear that striving to return to normal is not the right goal. Given that communities of color will bear the brunt of the impact of a surge in infections resulting from a rapid reopening of the country, I argue that following this path is a racist policy. That assertion is borne out by the symbolism that some reopen protesters have chosen. If we want to avoid this path, we need to embrace explicitly anti-racist policies. So what does this look like? We have some great examples in our state. At the state level, the COVID-19 Health Equity Response Team was established by Governor Polis on April 17th. What this task force does is to focus on providing access to data on race, ethnicity, and COVID outcomes. Shanta, in her talks, talked about the COVID racial data tracking project, which is really key to documenting these disparities and addressing them. This task force also focuses on looking at ways to prevent spread in vulnerable communities, addressing underlying health disparities, and developing policy recommendations. At the city level, another example is in Boulder, where the racial equity team at the city level has embedded members into all of its COVID-19 response and recovery teams. And they've implemented a rapid assessment tool that asks who benefits and who bears the burden of each proposed action. So beyond these COVID-specific efforts, the good news is that we already know much of what needs to be done. A wide range of anti-racist policies in different sectors will address COVID-related disparities and make our society more resilient and equitable overall. This includes the policies that Dr. Franco-Paredes mentioned when it comes to incarcerated populations. It also includes expanding protections for workers and promoting policies that foster heavy living environments for all. As a key example, studies are showing a linkage between exposure to air pollution and susceptibility to COVID. In Colorado, this is a environmental justice bill that is currently under consideration by the state legislature. This is one attempt to mitigate the disparities in air and water quality as just an example of a policy that is fostering these addressing underlying disparities that address lots of issues. So what can you do personally? Again, I have good news. Policymakers that I've talked with emphasize that they're eager to listen to the voices of doctors when it comes to setting priorities and passing legislation. It has also never been easier to show up. So a lot of the hearings and meetings are happening remotely right now. This can also be as easy as providing a letter. So your white coat or the MD after your name is very powerful in policy advocacy. People like Dana Kennedy at the Center for Health Progress, whose contact information I've put here, are eager to guide you through this process. They are very skilled in sort of letting you know what you can do and where your voice would make a difference. So I urge you to reach out to her or to me if you're interested in joining the fight. Thank you.
Well, thank you. That was really superb. Let me start out with a very broad question. If you were to turn back the clock 4 months, what would be the 1 or 2 things that you'd put in place to prevent this pandemic or prevent the maldistribution of cases in this pandemic? And how does that relate to what you would put in place and prioritize to prevent the second wave? And I'll open it up to all the speakers.
It probably varies for each of us in terms of the lens that we're looking at and the patient population that we're talking about serving. I think from the side of the inpatient hospitals within our academic centers, and I include all of our partners in that, I think a clear communication about the need for transparency about how the communities were being impacted right out of the gates, rather than finding this as a surprise, would have been one step, including supporting our patients to be able to stay at home and to have access to appropriate masks, hand hygiene, things like that. And I also think communication of the messages about what it means to social distance in multiple languages and through places where our patients would potentially receive them, including through the public school systems, through workers' unions, through potentially our grocery stores, making sure that we got the message out there that we wanted people to be able to keep themselves safe, but that we were also here for them if they were sick so that they could come. And of course, tightly linked to that is testing and the ability to access testing right off the bat.
I want to echo what Shanta said about testing and access to testing, but separately, I described the 5 boroughs, and yesterday there was an article in the New York Times describing more details about what residents in the Bronx had experienced. And so it's interesting, and I think that an important thing that needs to happen is that we need to engage these communities early on and intentionally create the information that is going to be language and culture appropriate, but also provide the resources and means that they need. And so I think partnering with our communities that we know have lower resources and with the nonprofit groups that work with those communities is crucial. For example, in the Bronx, in this New York Times article, they described the River Park Towers, which I guess are 2 very tall towers. They're 44 floors. There's about 5,000 residents, and over, I think, 70% of the people that live there receive rent subsidies. And what they described in that situation is that many of the residents worked, jobs that they, that were necessary, the necessary jobs. And they had a wait of about an hour just to squeeze into an elevator. And so they were being squeezed into elevators. The buildings weren't being sanitized and cleaned appropriately. There was no ventilation. And because of the crowding in the hallways and the sanitation, there was a lot of, there was a high case rate. I think right now they think over 200 cases, but they're unclear because I guess the landlord also passed away from COVID-19. And so I think, after reading that article, it made me realize that each neighborhood, each community's needs are different. And for the second wave, what needs to happen is very intentionally engaging them early on to see how they think they can best protect themselves and how we can meet those needs.
if I,
Any other thoughts, Carlos?
yes, so I mean, I would just, trying to connect some of the dots that we discussed here, and to answer your question, I mean, I think, what also was quite interesting to me was that I believe it was February 26th, there was an editorial in the New York Times by the editors who talked about, how important it was to focus on, based on the fact that jails and prisons in the US had such huge populations, to start thinking about, the carceration and the population of some of the jails. And in the state of Colorado, I think if we talk about jails, which includes those facilities that are usually county jails, they have individuals who are detained um, pre-trial in the majority of cases, and then some people have been sentenced to less than 1 year, and then people who are sentenced for more than 1 year go to prison, which are usually the state prisons or the federal prisons. So here in the state, one of the things that happened is that many many sheriffs that control these jails or that direct these jails, they actually started doing it before probably other places in the country. There was only one jail, which is Weld County Jail, who didn't do much until later. So it is, I think, depopulating jails is a major strategy here, and I would continue to foster that. And we're not talking about here, human rights or anything else. I'm talking about public health. I think there's alternatives to incarcerating, particularly in jails, that could assist this, and we can provide safety for everyone. The last comment, if it's okay, just to add, is the Prince George's County Jail, which I inspected at some point in April. Is that, early May. It connects the dots in a way that I think is interesting. Prince George's County has mostly African American groups as well as Hispanic in the community. They actually work, for the most part, those that work for the DC, Washington, DC district. And what is interesting though is that I think that explains in a way what Shanta, what Lily, and what Kathy presented, is that these individuals, they may have some increased risk factors such as, maybe diabetes in a higher rate. But what really was clear in this case was that, or in the state of Maryland, is that this county has the most cases in the state of Maryland because these people have to be exposed on a daily basis. It's a luxury to be able to achieve some social distancing because they have to provide for their families and so on. And this is, at the end of the day, what connects it to the jails and prisons, because if you have many cases out in the community, some of these correctional facilities, so correctional officers, or the new detainees going to the jail and continue the chain of transmission. So it is all connected, as I mentioned earlier, but depopulating jails continues to be a major priority, as well as the immigration detention centers.
Thank you, Carlos. Let me ask a sort of related question. How much of this is socioeconomics and how much of this is race? What do we know about the crossover populations, the European Caucasian individuals that are poor, or the African American and Hispanic individuals that are wealthy?
I think Katie hit on a lot of these issues in her discussions around the disparities that exist in ability to stay at home and to socially distance. Without a vaccine, that's the most powerful tool that we have right now. And most of us in the physician workforce and in the academic medical center have been able to stay at home. And that's related to our socioeconomics, but also to the types of work we have. When we come to work, obviously, we're very well protected. Others are not so much. And so I think it's the folks it is a socioeconomic, and those jobs that are part of the service professions are the ones that are really the front line of the pandemic. I think about it in the terms of the people who deliver the food to my house or the packages that I've been receiving, folks who were staying late working in restaurants. The students have been digging into this issue a little bit in the data that they've been collecting from the patients hospitalized at University of Colorado Hospital. These are the kinds of things that we don't always put in our HMPs, but how many people lived in the home of the patients who were admitted, what occupation did they have. Many of the patients were working at the Denver International Airport before many of the flights were canceled. So we looked at people who were travelers early on, and we forgot to look at the people who were taking care of the travelers as they came. So I think socioeconomics is a big driver. As was mentioned by everybody, identifying particular genetic factors that are related to race are difficult to do. I do think on the issue of comorbidities, where we see excess comorbidities even among different socioeconomic distributions for things like diabetes and heart disease, that there are other contributors, including structural racism, including the impact of microaggressions on cardiovascular health and the stressful environment. We tried to call out the recent shootings, and those contribute to the stress levels of all of our colleagues who are African American and Hispanic.
Good. Let's talk.
Can I just provide a quick answer as a non-MD doctor? So going out on a limb here a little bit, because this isn't exactly my wheelhouse, but one of the pieces of evidence that I found really compelling in separating the role of racism from socioeconomics has to do with maternal mortality, where we do, from what I understand, see much higher rates of maternal mortality among Black women, regardless of socioeconomic status. And I think, with that evidence as well, people have found, for example, that recent immigrants to the US, there's sort of this immigrant paradox where recent immigrants don't show that disparity. So it seems to be an prolonged exposure to racism in the context of the US that is contributing to that. There are hypotheses around weathering, like Shanta said, sort of prolonged exposure to the stress of discrimination and racism. So that's something that I think I had posed to some folks in this group. I think it'll be really important to look at those disparities. I think anecdotally, we've certainly seen, cases of young Black teachers in New York dying, but of course that's anecdotal, and looking more systematically, I think, at that question of how much of this is race, how much of this is racism, and how much of this is socioeconomics, I think, is an important area that I'd like to see more work.
Mm-hmm. Yeah, I agree. It's really important to sort that out, because sorting that out will help to a certain extent in terms of identifying the solutions. So one of our questions focuses on people released from jails and prisons. And the question is that just releasing someone from a jail or a prison without a plan in place, without housing or health care in place, may not be sufficient to prevent the development of disease. What can we do at UCH, at Denver Health, at the VA to address these problems when we see it occurring?
Thank you, David, for that question. I think that's a crucial aspect of pushing or like fostering, talking to some of these or being on a hearings with different judges. It's been I would say a tough experience, but very rewarding when you have to justify exactly that question. Like, what are you going to do if we release more people? So what are the plans that you have to support these communities? And thankfully, in the state of Colorado, we have the Criminal Justice Reform Coalition led by Christy Donner, as well as a very, very, I would say, tight group of community re-engagement groups. And I will mention one called Second Chances, which is run by Hassan Latif. And Hassan is a wonderful man. And we work with him, I work with him, and Martin, my colleague Martin Kershak, Nick Juan, who's a student, and then Shelly Kohn, who's an ID fellow. we actually, just to give an example, and it's not self-promotion, but it's more to tell you how, because when we started seeing people being released, that question came up. And Hassan and his group, they have at least 4 different facilities where the largest part of the funding for these activities come from the Department of Corrections. So the Department of Corrections have for many years looked into these, and there's actually an appropriation law to provide, I would say, millions of dollars every year to assist these even before the pandemic. But now that the pandemic happened, for example, they receive additional funds to be able to pay for a hotel or a motel where they can have these extra people who've been released. So there are many community re-engagements organizations in the state of Colorado. They're all super active. And I would like to mention again Christy Donner, because I think she's a superhero. She provides a lot of this coordination along with many other people. Just another example, David, which I think is relevant to say, is that the state of California, in just 1 week, and this was a historical thing, the health department, the different NGOs, the community re-engagement groups, they were able to coordinate 2.6 million people were released in a period of 7 days. And the coordination was, I can't even imagine how to achieve that, but they were able to do it. And that was a good example that I think other states should take into account to make sure that, these people will have a safety net. Number 2, that they will have medical care, that they also will be able to comply with parole officers and probation officers as well, and have a system where we know that they're okay, and provide information, education to make sure they understand about the symptoms. Because also one of the things that happen is that we identify is that their connection to knowledge about what happens outside these jails and prisons is usually their communications on the phone with their families, and what they listen on TV or on newspapers, and the family member or the girlfriend or boyfriend passing into the detainee. So many times they don't have all the information that we have on the outside world, and I think it's important to guide them, inform them, and just basically work with them on a daily basis. So we do participate actively, and there's in Colorado, just to summarize, a significant network of people participating in this effort.
Great, thank you.
Sorry, I was gonna just jump in very quickly. As an economist, I think it's all I think the tendency is to say that those measures are very costly to, take care of folks and kind of guide them through the process as we're releasing people from jail and providing all this, social support. I think this pandemic has shown very clearly that there are huge costs to not having an adequate safety net, right? So we are all bearing that cost right now, and so I think in addition to, I think it's very important for us to just remember that not taking those actions, that not taking care of the most vulnerable in our society also ends up imposing huge costs on all of us.
So Katie, I have to ask you the question then, as budgets are cut and as budgets are constrained, we know that the state of Colorado will have a $3.3 billion shortfall this year. How do we protect these programs?
Yeah, I mean, I think the right questions are, I was thinking about that earlier when you were, when you asked the question about going back 4 months, and my immediate thought was, a lot of what we're talking about was already baked in 4 months ago, so it would have been hard to make a lot of changes at that point. I'm sure there are things that we could have done to reduce the burden, but I think as we're going forward, again, I really like the example of what Boulder is doing in terms of embedding racial equity into all of its decision making, because again, I think that the question is, I think there's a tendency to say we don't have, this is not a time where we can afford to invest in solving these disparities. But I think, again, my argument would be this is a time where we can't afford not to. And not all of the things that we're talking about are hugely costly or change the cost calculus. But I think having a framework like, the checklist that they're using, where they're asking with every single action, how does this affect different communities? Who's going to benefit? Who's going to bear the burden of this? And is that an action we want to take? I think this is just a crucial time because, again, I do think the tendency is going to be to say we can't afford to do that new thing, and to look at it in a narrow way that doesn't, again, take into account the hidden costs of not taking action.
Mm-hmm. Very good. Let's get on to public school systems and how that plays into this problem. Access to education, the effect of education, the type of education, and the reopening of schools, public schools, and how that affects communities. Who wants to take that on? This clearly could affect the distribution of disease within these communities as we begin to think about social distancing. And the absence of education clearly affects the ability of parents to go outside their home to earn a living during this pandemic.
If I may take on trying to answer that question, David. I think the example of the 2009 influenza pandemic, which began in Mexico, in mainland Mexico, that's the country. One of the things that happened early, and it has been studied, the impact of school closings into decreasing or mitigating the pandemic in Mexico, which was then occurred in other places, was very significant in terms of what it achieved. As we know also from like the 1968 pandemic in Hong Kong, it was found that, a lot of the children were actually, were affected, and some unfortunately died. But there were also, what it was found back then was that it became the driver of transmission in the household. And again, the point being here is that after the 1968 pandemic in Hong Kong, Japan decided as a policy to vaccinate children against influenza because of this identification of the household transmission of flu from the kid who goes to school, comes back with the flu, and then provides transmits infection to their grandfather or grandmother, and then the grandmother dies or the grandfather dies. So after that, what he was using is actually the only study, as far as I know, that has shown that decreasing mortality from influenza in the elderly were by vaccinating children, and in a way was again to protecting those school-age children. So I think from a public health perspective or epidemiological perspective, it is an important strategy. I think that to get to the core of your question, just to give you that background, I think that the next step is to figure out ways where you can do this safely. And I think there's different approaches. I know that the president didn't want to use the CDC document to help with some of these examples, but I think one approach would be to, maybe more testing, maybe serological testing, in a way as immunity passports in the community may help out to reopen schools. I mean, I don't know exactly how would I do it because don't have the expertise or the understanding, but I do think that despite there's been a lot of resistance to accept the idea that, for example, using IgG for seroprevalence studies may not be, some people are not recommending it. It seems to me that it is, we have enough information at this point to be used for trying to restart the economy, to trying to restart schools, and so on. But I do think that that we need to pay attention to the fact that sometimes by, at this point, we have to be careful. But there's so many people in these families, particularly in some of these public health schools, where the parents do have to work on a daily basis, and that there will be a risk that we cannot afford unless we have some plan.
I just want to quickly add as well. Oh, sorry, Shanta, were you going to say something?
I was just going to say, I don't think we understand the science of this disease in children yet. And so I think before we would recommend a plan, we need to make sure that I think the serosurveys are going to be helpful to help us understand whether or not we really did have a large cohort of asymptomatic children, or if no children are infected, then we need to call into question how much they're contributing to driving the disease. It's very clear in influenza and other respiratory viruses that children and school children in particular drive to the disease. That was very clear in 2009 with our pandemic, with the timed perfectly with the opening and closing of schools. But I don't think we understand it as well in COVID-19. And so making policies without understanding that is going to be difficult. I do think having foresight about vaccination and access to vaccines and education about vaccines so that there's not fear in the communities and that there's access to them potentially through school-based clinics is going to be an important planning strategy as we start to do it. And I agree with Katie's comments about weighing every decision that we make with the potential downstream impacts that it would have on vulnerable communities, whether that's access to school lunches and food, if it's the inability of children to be able to stay at home safely. All of those things are going to have consequences on the kids when we decide to open the schools, and we shouldn't open them in a way that we think more affluent families can handle, but think about what our most vulnerable families can handle instead.
Lily,
Yeah, I echo what everyone else has said. I just wanted to add that income and education are two of the social factors that most strongly correlate with life expectancy. I saw a question in there in the Q&A that, sort of a question about investment in education, and especially during the second wave. And I think, as Shanta said, we really need more data, because in that slide where I showed the Denver neighborhoods, those neighborhoods that have been most affected are also the neighborhoods where we see very low high school graduation rates. And so we need to understand how they've been impacted by the changes in education during this first wave, and again, engage those communities to see how we can best improve education for those communities. Because what we don't want, what we want to avoid and be very intentional about, is that these communities don't continue to be left behind, especially with regard to education. And I know I've said this before, but I'll say it again. Like I grew up in the Westwood and Valverde neighborhood, and my life expectancy would have been 12 years shorter had I not, had the opportunity to pursue a medical degree and, now live in a different neighborhood. And so education is crucial and something that we need to advocate for.
Good, thank you. The issue of meat packers was brought up, but it raises a larger question of what occupations are at risk and what are the characteristics of those occupations that are at risk. How is this being studied? Is it simply crowding in the workplace? No takers. Okay.
Katie, I feel like you have the most information on this, but JBS, the meatpacking group in, I think it's in Greeley, that has the highest, I think they've had about, I have some data in here, they've had about 300 cases, and the Denver Post just announced the 8th death last week. And they provided some demographics on those folks at the JBS, and they are absolutely more than 50% racial ethnic minority, some undocumented as well, but they can't release some of that data. And so I had a slide in here that I got rid of, but basically showing that a lot of the jobs where people aren't able to work remotely that are necessary are, of course, disproportionately racial and ethnic minorities, like grocery, construction, restaurant business, and, again, the JBS meatpacking example here in Colorado, which has been one of the biggest hotspots for the state.
Yeah, I was going to just point folks to the Center for Health Work and the Environment in our in School of Public Health. I think they're doing some really good work looking at in general, looking at the role of occupation as a social determinant of health, and then in this particular context, yeah, I think that's right. Really, what you were pointing to, what are occupations where people have to be in close proximity to one another for extended periods of time in indoor spaces, and where, potentially you don't have, in the medical setting, a lot of those things are true, but there's also a strong focus and, on personal protective equipment and, hygiene procedures, all of the, right, there's a very strong awareness and ethic that keeping folks safe is the priority, and that's not the case in a lot of professions. And the ability for, I think this is another place where I had on one of my slides, whistleblower protections are very important, so that folks feel comfortable or feel like they are able to speak up when their employers aren't providing a safe work environment, and that they don't fear losing their jobs if they do that.
Another place where ability to quarantine is also important. We assume like, oh, you have an illness, so you should just stay away from everyone else. But if you live in a household that has multiple other people in it, 7, 8, 15, as some of our patients have reported, then the ability to quarantine and stay safe from spreading the disease is not there. So, asking for work employers to provide places for people to isolate, providing testing, contact tracing is another way to control and prevent some of these epidemics and outbreaks.
Lily, tell us a little bit more about this new Emergency Medicaid Act for undocumented immigrants. Does this relate just to COVID-19 infections, or is this more general? And how is it being rolled out by the state?
Yeah, so very, very exciting. They emailed a provider bulletin out on Friday. But just very briefly, the federal law that creates the emergency Medicaid program specifies that hospitals provide a medical screening examination when a patient presents with an emergency medical condition, regardless of ability to pay and immigration status. What's interesting is that CMS provides no sub-regulatory guidance for how each state defines a medical emergency and defers to states to determine those qualifying conditions. And so there are states like Washington, which, for example, have included not just kidney failure, but cancer treatment, outpatient surgeries, and I want to say there's 2 more. And as I mentioned, Colorado just added kidney failure this past February, and so that expands care to any undocumented immigrant or uninsured patient. It expands access to standard dialysis. And so with COVID-19, what the community advocated for was post-hospital discharge care. And so for all patients hospitalized with COVID-19 at time of discharge, they can now be discharged with oxygen and with 2 primary care visits, either in person or in telehealth. And this is huge, 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 because, we have to discharge patients that are undocumented, often without oxygen, even if they need it, because they can't self-pay. And so this is a big, big win. Again, announced on Friday with regard to communication, so that provider bulletin went out, and hopefully announcing it here, it's reaching several providers throughout the state. And I know that HCPF is planning on meeting with some nonprofit community groups with regards to how it'll be messaged to the patients.
Good. Katie, I was wondering if you could talk a little bit more about how physicians could get involved in advocating for support for programs focusing on social determinants of health.
Yeah, great. I'm going to go ahead and put this slide back up. So I had a nice long conversation with Maggie Gomez, who's also at the Center for Health Progress, and she was the one who, was telling me that anytime when they are, putting or supporting legislation, when they can find doctors to come either, show up in at the Capitol, back when we used to go to places in person, and provide testimony, or as she said, doing, writing a letter, providing written testimony. Those are very effective, and they again have a lot of experience in kind of walking people through this process. I think Dana is the right person to contact for that. I teach an environmental policy class in our department, and every day we have a public health day, or every year there's a public health day at the Capitol. This year I got to take my whole class on a field trip, and I think one thing that the students all come away really impressed by is just how accessible the Capitol really is, again, in normal times. But I think, compared to the federal government, the state legislature is a place where a lot of things are happening, and there are a lot of, there are, MDs and medical professionals who are part of the, who are members of the General Assembly. And so they are very sympathetic to and very knowledgeable about these different topics. I think there's, again, politics can, I think a lot of people are very turned off by politics these days. I think engaging at the state level, for me, has been something that gives me a lot of hope. I think there's a lot of good things happening, and the bar to getting involved and participating is actually very low.
And David, if I may add, I think that this is truly, I think, an opportunity to create actionable change. What I hope is that we don't chronicle these poor outcomes from COVID-19 with other disparities like maternal mortality, as Katie described earlier. And I think that for clinicians out there, if you're truly passionate about one area in particular, like I was passionate in undocumented patient care, I found nonprofit community groups, and I engaged health policy stakeholders on those critical gaps where research could answer some questions and move health policy. And so I think that if there's something you're truly passionate about, create an outline and framework for how you can create change. If education is your thing, start connecting with folks that are involved in education policy reform and DPS. And there's a lot that can be done if you have a targeted sort of approach.
Mm-hmm. And when you have a targeted approach, your targeted approach for you was undocumented immigrants. And how do you create that sense of trust and safety with undocumented immigrants that are at such high risk of being deported?
That's a great question. It's taken years. A lot of my research is possible because the research staff that works with me is all Latino. And so, they have developed a trusting relationship with the patients. And to be honest, I just show up. I go to the nonprofit community groups when they have their gatherings, and when they ask for help on something, I just show up. And I think with time, you can begin to build trusting relationships and rapport. I have found that to be the most effective if they know at a granular level where you're coming from and why you care, and you connect with them or develop that personalized interaction, then it's easier to not just conduct research with undocumented immigrants, but work with them to advocate for health policy change. Like, for example, with the research that's been published, when media reached out for interviews, it's incredible the number of people that volunteered to be interviewed, even though it meant, being on TV and being at risk for being deported. But they were there, and so those meaningful relationships helped tremendously.
Yeah, I think we're going to end on that very positive note, Lily. Thank you for your comments, Shanta, Carlos, Katie. Really appreciate your presentation and your answers to the questions. This is a really important topic. It's a key driver in terms of who gets a coronavirus infection and who suffers the consequences of coronavirus infection. And we need to really focus on the health determinants as it relates to race and socioeconomics, and identify the policy changes that we can support as healthcare providers to make the environment much healthier for the people that we serve. So thanks very much for addressing this topic. I'm sure you'll have a lot of inquiries from the individuals that attended the talk.
Thank you.
Thanks, everyone.